First off, let me just thank Claire for that warm introduction, and also the Alzheimer's Disease Center the Alzheimer's Association for putting on this very important conference and inviting me to be part of this. It's truly a deep honor and privilege to be here today and to talk to you about something that I'm deeply passionate about. And I think it is never too early or too late to think about how to best preserve our memory and thinking skills. So, as a first question, whenever I talk about cognitive decline, I think the first natural question that comes up is, what is normal cognitive change as we age? So, in general, we can all expect for some subtle changes in thinking that are not generally considered progressive. Most importantly, these changes are not accompanied by a functional decline. And in terms of memory, they're often described as kind of a sticky memory. Things are less efficient. It might take you more repetitions to learn something. Retrieval might be slow. Remembering someone's name at a cocktail party might be particularly challenging. Coming up with the right words in conversation. However, if you have a cue, that information is still there. It can still be accessed. The information hasn't disappeared. So the purpose of this slide is to confuse you. And this is data. This is a lot of ways that we know about cognitive change and what's normal and what's not normal comes from what we call cohort studies, where individuals from the community are invited to participate and be studied across their lifespan. And so every year they undergo batteries of cognitive testing and other types of assessments, and then at the end of life, oftentimes they're asked to donate their brains for studying the underlying pathology. And so this is you're going to see graphs like this sporadically, so I'm going to take a little bit of time here to explain. So this represents cognitive change across a very long span of participation in one of these types of research studies. This data actually comes from the Religious Orders Study, which is a nationwide study where individuals that were priests or nuns or involved in a religious order have agreed to participate. And part of the participation is they've all agreed to donate their brains at the time of death. So on our y-axis here, we have an overall measure of cognition. And so essentially, the details aren't too important here. What you want to know is that higher is better. So this is in standard deviation units, which is just a way of talking about how similar people are to the average. And so at 0, that's considered the average. The higher you go, the more someone is above average, and the lower, the farther away from average. And then these individuals were studied across more than 16 years. And each one of these lines here represents a single person who's involved in this study. And so the main point of this is that, can you discern any pattern here of how we should expect to how our cognition should change as we age? I can't visually. Some people seem to be going down, some people seem to be going up. This is not subtle data, it's a collective over across all cognitive domains.
What's the difference between solid lines and...
So each one of these lines represents one person in the database. There's no difference. Don't try to understand this graph. So,
Well, why show it?
right? Okay, I'm going to get to the punchline here. So that's looking without any kind of statistical methods. So just plotting out people's change. And so the point there is that there's a lot of variability, and we have to use advanced statistical methods to look for patterns of change. And so when these methods are applied, we can actually find 3 clusters of types of change amongst people. So, and this is from the same data, but made in a more understandable format. So you see these black lines here. This reflects, and one thing I forgot to mention about these individuals is at the start of the participation, everyone was free of any kind of cognitive impairment at the beginning of participation. The black line here reflects the majority of these seniors. So 65% had a slow change. So in statistical terms, this was about a 1 standard deviation change over the course of 12 years. Well, what that means in terms of practical applicability is that it's essentially, across 12 years, you can say, yeah, there's some kind of noticeable change. I'm not as efficient as recalling new people's names. I might need more repetition. So things that could be noticeable, but very subtle. There was a sizable minority, around 27%, that were reflected by these green lines, and they demonstrated a faster change. So for the same amount, that 1 standard deviation of change, the same amount of change as the slow changers, this change was happening at a faster rate, more like at about a little over 2.5 years. So that's a quite more significant rate of change. An even smaller minority, less than 10%, demonstrated by these purple lines, have quite a rapid rate of change. So for that same amount of change is happening in less than 1 year. Follow-up analyses of this group suggest that really the individuals who are changing at a faster rate, that there is some kind of underlying pathology that is happening there, accounting for that rate of change. That doesn't mean that the people in the black group, the slow changers, they are not disease-free. And that's a very interesting and important point that I'm going to be coming back to repeatedly. They're just not having symptoms. So I want to make sure, I think this group probably knows these terms very well, but very quickly, just to make sure we're all on the same page on terminology, I'm going to quickly review our clinical diagnostic terms here. So in my clinical capacity, I like to say that I have 3 different diagnoses that I'm looking at, or ways of describing people that come to our clinic. My first and favorite one to describe people as is that there's no change. There's no diagnosis. The second is a mild cognitive impairment. And this is when, for example, on neuropsychological testing, we may observe some very mild cognitive changes. However, they're not severe enough to interfere with the person's daily life. They may or may not be noticed by the person or their family. And it could be, such a problem could be in any type of cognitive domain. So memory is what we typically think of as an initial symptom, but you could have language changes, visuospatial changes, changes in executive functions, which is how you control your thought processes. And there's many causes. Sometimes we think the underlying cause looks similar to Alzheimer's disease, but it may or may not be progressive in nature. So then we have the diagnosis of a dementia. So those are the 3 diagnoses that are given. So a dementia, most importantly, is a syndrome. It's not a specific disease. There's many causes of dementia. It's just a label, just to classify people. This largely helps us understand how much help someone needs in a given situation, but it's really just a snapshot. It doesn't reflect necessarily the nuances of a person, but it can help us with both research and in clinical usage. So it's not a specific disease, but there's an impairment that is really considered to be persistent. So this is not the effect of a medication or something that's transient, not the effect of having a brief illness that could influence your thinking. There's more than one cognitive domain that's impacted, and the extent of impairment really does impact a person's daily life. So they're just simply labels that are attached. They don't reflect an underlying disease course. So just as with the MCI diagnosis, they may or may not be progressive. This is just to reinforce this idea that the term dementia is just an umbrella terminology. The underlying, so then we make the differentiation of what is the underlying etiology. Most commonly, from these autopsy studies, we know that the most common reason or the most common pathology that accompanies cognitive change as we age is Alzheimer's disease, followed by cerebrovascular disease, and then there's some lesser common pathologies as well. So those are at individual levels, but one of the most significant findings that we have now is that we've learned from these cohort studies is that more often than not, individuals who are suffering from a dementia, so their cognitive symptoms have progressed to the point that they're no longer having a completely independent functioning in everyday life, more often than not, these individuals have mixed pathologies in their brain. So to show you, so there's three main points I want to take away from this slide. One, so we see people who at the time of death did not have a dementia diagnosis are demonstrated in blue here. And you can see that even amongst those individuals who were free of a cognitive diagnosis, quite a sizable percentage have Alzheimer's disease pathology in their brain. And quite a sizable percentage have evidence of cerebrovascular disease or an infarction in their brain. This is like the leftovers of a stroke. And then, around 20% have a mixed pathology. And there's actually few community-dwelling older persons that at time of death are free of any kind of brain pathology at time of death. So then if you look at the persons who have a cognitive diagnosis that is impacting their daily living, again, we see Alzheimer's as a single pathology. Alzheimer's disease definitely leads the way, followed by, just as I was saying before, cerebrovascular disease or infarctions and other lesser common ones. However, the bulk of people who have a diagnosis at the time of death actually have a mixed pathology. And so the real important message there is that while at the present time, and I hope to be part of the solution to solve this problem, but at the present time we don't have a cure for Alzheimer's disease, this message tells me that cerebrovascular disease infarctions, these are much more modifiable in nature, and so as a country, as individuals, we have a lot of room for improvement, even prior to finding an absolute cure for Alzheimer's disease. We have a lot of movement of decreasing the number of people who have cognitive impairments that manifest in a way that impacts their daily life. So looking more at vascular risk factors and risk of dementia, this is data that comes to us from Kaiser. It's from the Kaiser Permanente group. So these individuals were first enrolled in this study when they were 40 to 44 years old, and they had more than 6,000 people enrolled. And then they studied them for 27 years. And after 27 years, they looked at their diagnosis of dementia and how that was related to those vascular risk factors early on in life, in your 40s. So traditionally, we think of vascular factors. We don't typically think about them when we're 40. We think about them as not really playing a big role until they've become significant problems in our lives. However, what we now know is that even in as early as our 40s, keeping control of those vascular risk factors will likely influence our chances of developing a dementia 27 years later, with the top contributors being diabetes, followed by cholesterol and hypertension. And then the smoking here is smoking at any point in life. So we're actually going to so if you have any questions, write those down, and because we're going to have that question and answer period. So that was all cause dementia. So again, not trying to specify what the underlying etiology was. When we look at the risk of developing a dementia that looks like what we think is Alzheimer's disease, so there's some kind of biomarker support there, or some support that really suggests that Alzheimer's disease is playing a role, we still see a dramatic impact of vascular risk factors. So as we see across the cumulative risk increases as we have more and more of these vascular risk factors. So even for people for whom we think that Alzheimer's disease is really the driving force of a cognitive decline, it's the addition of the vascular risk factors that's influencing whether or not individuals are expressing symptoms in their daily life. That's one hypothesis here that this data is supporting. So I think that then leads us to think, well, how much of our symptoms, how much of our thinking abilities, how much of our brain functioning is determined by that pathology? I think when we hear the terms Alzheimer's disease, when we hear Lewy body disease, when we hear these very scary words, it seems inevitable. It seems like a death sentence. It seems like the trajectory, that there's nothing you can do about it. So again, coming from these cohort studies where people have donated their brains at autopsy, and they've been doing these cognitive tests year after year, we've been able to look back and say, if we know what pathologies in their brain at the time of death, can we predict how well they were doing cognitively right beforehand? And so if you think about a person's thinking skills as a pie, right? The amount that we can predict about that pie, knowing all of the degree of pathology, including the cerebrovascular disease, the amount and extent of Alzheimer's disease, it only allows us to predict about 41% of a person's functioning and thinking skills. That's not even half. That's a sizable impact. That's a huge piece of pie, but there's a lot left over. So another way of saying that is that one person could have a very small amount of underlying plaques and tangles, the pathology of Alzheimer's disease in their brain. And they may develop significant symptoms and have a diagnosis of dementia. Another person may have a brain riddled with plaques and tangles and have quite a bit of atrophy, shrinkage of their brain, and yet have no symptoms on sensitive cognitive testing and in daily life. So it tells us there's a lot left to influence besides just the underlying pathology. We hope to influence the underlying pathology, but our ultimate goal is really to retain independence, to keep our memories sharp, to stay active in our lives. And I think this data really suggests that there's a lot we can do even as we're searching for a cure for the pathologies themselves. So switching gears here, what are some of the behavioral factors that research has suggested might contribute to that pie, that might account for some of the other portions? So there are many factors that have been investigated in the literature, and my other colleagues here from my center can attest to that. I can speak about them all day long if given the opportunity, but given the time constraints, I'm going to focus on some of the most supported or the most vigorously investigated. So first I'm going to talk to you about the evidence for the role of physical activity. Then we'll talk about cognitive and social engagement, diet, and then sleep. You'll notice in your slides, and I apologize, I was a bit overambitious when I first made my slides, and I wanted to talk a lot about also how to apply some of these things in your daily life. Those slides are still, I think, in there for you. And feel free to ask questions during the question and answer period. But I wanted to leave the bulk of the room to kind of go through some of the things that are not as easily digestible. So turning to physical exercise, the main takeaway about physical exercise is this slide really takes it away. If we had a pill that delivered the effect that physical exercise has, it would really be considered a miracle pill. It outperforms any drug that's out there on the market. So why is that? Well, this is another one of these slides that is more for the effect rather than the details. So typically when you have a drug or a vitamin or something like this, the pathway that it's making an influence has one pathway. There's generally like one basic mechanism that we think is having the impact. Well, with physical activity, this middle column here shows you just the broad range of pathways or mechanisms that the physical exercise is having the effect, right? So, compared to, it's like taking 20 drugs, but instead of one drug, right? You're having a lot of different pathways. The other thing is that we have direct effects on things like cognitive functioning in terms of the health outcomes that are related or decreased risk of stroke. But we also have indirect effects. So exercise is very effective at managing depression, at weight management, of reducing fall risk. All of these things would be more not necessarily directly impacting your cognition, but they will indirectly serve a protective effect. So there's just a lot of pathways that exercise can be beneficial. So this is data from an epidemiological study, so one where we're just observing populations in the community, thousands of people, large groups of people, and they were followed for 5 years. So at the beginning, and then looked at the beginning of the study, the individuals were free of a cognitive diagnosis, and then studied for 5 years to see how their level of exercise influenced their chance of developing a dementia later, or a cognitive impairment later. And they were, at the beginning of the study, they were divided into groups related to their level of exercise. And then categorized after 5 years as to whether they met criteria for a mild cognitive impairment, any form of a dementia, or a dementia that we specifically think looks like an Alzheimer's disease. And the big takeaway here is, so the blue group is the no exercise group. This is truly sedentary. They're not engaging in regular walking and could be considered a sedentary group. And if you, I think it makes the point by itself, the blue groups, their relative risk of developing a cognitive decline is quite a bit different than all of the levels of other exercise. So regardless of whether it was low, moderate, or high, you know, there might be some benefit of increasing the level of exercise, but there's a clear difference between people who don't exercise and people who do exercise. So that was from an epidemiological study, so just an observation. Actually, let me go back to that. So that's a nice suggestion, right? But exercise is kind of hard, and who wants to do it if you're not really sure you're going to get any results? Maybe the reason you have this result is that people who have an underlying pathology in their brain, perhaps they aren't as motivated to work out. Perhaps they don't have the energy. Perhaps there's some other reason that could explain why people who are not working out at the beginning, who are not engaging in physical activity at the beginning, are more at risk. So we need another level of data. So typically that a more advanced level of data to support the role of physical activity before I'm going to recommend it to my patients as a way to invest their time is through a randomized clinical trial. So we're holding questions till the end. Yeah. So this is data that comes from one of these randomized clinical trials, and they randomized about 120 men and women into different levels, into either a stretching control group or into a walking exercise group, where 3 times a week they walked at a vigorous pace for about 40 minutes. And then they followed them for a year. And they looked at both their cognitive functions and also their brain volumes. And they specifically were looking and interested at the hippocampus. So the hippocampus is essentially your brain organ that's responsible for laying down new memories. It's also important because most of the brain, if the cells of the brain die, you don't get them back. The hippocampus is one of the few places in the brain where cells actually regenerate across the lifespan. It's important in this context because it's also generally the initial site where Alzheimer's disease starts. So it's particularly important there. So then the results of the study are presented on the graphs on the bottom. We have 2 sides to our brain. So we have the right hippocampus and then the left hippocampus. The 2 groups were presented, so we have the exercise group in the blue lines and the stretching group in the red lines. And so you can see at the beginning, at the baseline, the 2 groups are fairly similar. So there may be a slight, in the exercise group, there was a slight, their hippocampus on the right side was a little bit bigger to begin with, but overall, the main story here is that across time, the difference between these two groups in terms of the volume of their hippocampi really changed, so that across over 1 year, they are pretty dramatically different from one another. So normally, what's considered normal changes in your hippocampus as you age is about a loss. So it's normal for your brain to shrink as you age a little bit, even when there's no underlying pathology. And the hippocampus specifically decreases at about a 2% volume loss per year. For these individuals, that's what was happening for the no exercise control group. For the exercise control group, it was essentially as if you reverse time by 2 years. That's about how much volume gain they got. So that's really remarkable when you expect, as part of normal aging, to actually be losing volume, to not just stabilize, but to really increase your volume. So, okay, that's compelling evidence to me. These were healthy individuals free of any kind of cognitive diagnosis at the time of their participation. Okay, so we've got clinical evidence supporting making that a recommendation for healthy people. Well, in the face of disease, does exercise do any benefit? We don't want to just give that recommendation out if it's not going to make a difference. So this has been replicated in a trial with exclusively looking at women with mild cognitive impairment. And that's because there are some hormonal differences that can interact with brain volumes. So that's why they focused on women for this. And they were divided into 3 different types of exercise groups: a resistance training, aerobic training, and the balance and tone group, which was essentially like their stretching control group. It wasn't very much activity there, but they all got the same number of hours of attention in an exercise clinic. The aerobic training for this group, they really focused on targeting heart rate rather than number of minutes. And so this is in a group of people who already have a cognitive diagnosis, and they replicated those findings. So amongst the people who were in the aerobic training group, they had stable and larger hippocampal volume compared to the stretching control group. So great. So that's so for people with mild symptoms, we can say that exercise does help. Well, how about individuals whose cognitive symptoms have progressed to the point of having a diagnosis of dementia? Well, this is data coming from across 9 different Alzheimer's disease research centers in California, looking at individuals who at the beginning of participation were diagnosed with a dementia thought to be due to Alzheimer's disease. And they looked at their cognitive trajectories across 1 year. And what you found is that, at the beginning, there were not statistically significant differences between the groups based on how much exercise they were engaging in. But the individuals who were sedentary across 1 year had a decline in a cognitive screening test that would be expected for having a diagnosis of a dementia. However, those individuals who were walking about 2 hours per week, not necessarily at a vigorous level, had a stabilization of symptoms in the face of disease. So pretty powerful there. So then, well, what's the ideal amount? This is essential. This is a graph that comes from just public health data across all kinds of health outcomes, not specifically related to brain health. But across the studies, when we see that regardless of what health outcome you're looking at, there's a very initial steep benefit in terms of hours per week engaging in exercise and the relative risk of developing that outcome, that health condition. However, there's essentially diminishing returns to further time investment. So the biggest difference you're going to get, and particularly for brain health, is going from sedentary to non-sedentary. And that may seem like, well, how many people are really sedentary? How big of a problem is that? Are we going to actually influence that many people by going through that? So we actually know we have two ways of knowing about activities in older adults. We can measure through accelerometers, like pedometers, and see actual level of activity. We can also ask them about how often they engage in sedentary behaviors. So in large surveys of older adults, if you just look at their accelerometers, more than 60% of the older adult population is spending more than 8.5 hours of sedentary time during the day. That's their waking time. And similarly, more than 50% are spending more than 3 hours a day watching TV. So I think there's a lot of room for influencing people's behavior here. So turning now to cognitive and social engagement. What's the evidence here? So again, this is data that comes from one of these cohort studies. So the main point here is we once again have cognition on the y-axis, where higher is better, and then we have time and participation. This group, all the participants in this data had autopsy done, and so they were divided into whether they had a high level of pathology in their brain or a low level. And they were also asked about their purpose in life and how their feeling of whether they had a meaning and purpose in life. So they were divided into those people who endorsed a high level of meaning and a low level of meaning. And not surprised, so the black lines here are those individuals who had high levels of pathology. The blue lines are those who have low levels of pathology. And then you can see that the rate of decline in cognitive functions is steeper, it's faster for those who have a higher level of pathological burden in their brains, which makes sense. That's what we would expect. But the big surprise here is that the sense of having a purpose in life actually influenced that, such that the individuals who had a low purpose in life but high pathological burden, were similar to, the two groups get to be similar regardless of the pathology. So that even in the face of high pathology, having a sense of purpose, having a sense of meaning, appeared to slow down the rate of decline. And this group also found similar findings for social networks. So feeling socially connected, having a larger circle of social connections. Similarly, in terms of cognitive engagement, we've also found that engaging in cognitively stimulating activities influences the rate of decline in populations. And this is both in early life, so when people are asked about how many hours they spent doing various cognitive activities before their adulthood. Those individuals who spent more time doing cognitive activities during their upbringing had a slower rate of decline as older adults. So that's great for those of us who were big readers as a child. But they also found that at the time of study entry, asking them about how many hours are you spending engaging in cognitive activities, Things like reading, going to museums, going to the theater, pretty much any way you can imagine your brain being activated, with the exception of watching TV. And those mattered too. In fact, just as importantly as those early years in terms of protecting you as you age. So it's never too late. So in terms of diet, so the one thing I want to say about diet before getting into the specifics is that this is really it's a hot topic. People like to ask questions about what they should be eating. And it's also an area that's new in terms of how much data there is to support it. So I'm not going to be giving you specific recommendations today. But I can tell you what hurts your brain. So this is data that's from college students who were assigned to either have 4 days of breakfast that was a Western diet high in sugar and fat, or 4 days of having a breakfast that was not high in sugar and fat. And the rest of their meals weren't changed. They could do whatever they wanted. And they were only studied for 4 days. So they looked at a lot of various blood factors and other markers of health, but they also gave them a word list to learn and remember. And so these are healthy college students. At the beginning of this day one, the control group and the experimental group performed the same in terms of their ability to learn information. After 4 days of eating a breakfast high in sugar and fat, and these poor students, they were asked every day about this same word list. And so after 4 days of eating lots of sugar and fat, the experimental group was retained significantly less information than the group that did not eat that breakfast. So that's just in college students, right? So what about in older, as we age? Well, personally, I think it's safe to assume that those same effects are going to apply, that we're not going to suddenly do better with sugar. But in terms of diet, one of these cohort study groups has asked people about their dietary patterns at the beginning of their study entry, and then looked at how does that influence their rate of change, of cognitive change across their lifespan. And initially, they looked at 2 healthy diets. One is the DASH diet, so that stands for the Dietary Approach to Stop Hypertension. And the other is the Mediterranean diet. And so both are fairly similar, and actually they perform fairly similar in terms of predicting rate of change. So for both of them, the blue line is the highest adheres to the diet, and the highest third adheres to the diet had the slowest rate of cognitive change compared to the other individuals. And there was no difference between the DASH diet or the Mediterranean diet. They performed similarly. However, neither of these diets are specifically designed to protect brain health. The hypertension diet is targeting hypertension. The Mediterranean diet is a cultural diet. So the investigators went back and designed a diet that had specific research support related to brain functioning. So I'm not going to go through all of these, but these were the criteria of how they rated people's diets. You'll notice that people needed to get a score for green leafy vegetables. You essentially need to be having that every day. Berries you get a point for, but not other fruits. Which is the difference between the Mediterranean diet and the MIND diet, which stands for the Mediterranean DASH Diet Intervention for Neurodegenerative Delay, otherwise known as the MIND diet. So then they reanalyzed the data looking at adherence specifically to this more brain-targeted diet that was supported by prior research. And for this one, what we see is the difference between the lowest adherers and everyone else. So essentially, it was a more forgiving diet. If you were in the top 2/3 of adherers, you didn't have to be a perfect adherer to get a benefit from this diet. if, compared to the other diets. It also outperformed either the Mediterranean diet or the DASH diet in terms of being related to cognitive decline. So this is epidemiological research. It's not a randomized clinical trial. And so we want to be careful about having people making dramatic changes to their diets based off of epidemiological studies. However, there's an active trial going on right now that's a randomized clinical trial that's being done in 2 different sites in the country. So that will be exciting to see how that performs. But I don't want to give you the impression that this is the only diet out there that has empirical or theoretical support. Johns Hopkins is also doing an intervention study right now looking at comparing a high-fat, low-carb diet compared to a low-fat diet, high in fruits and vegetables and grains. So it's really a burgeoning area of research, and I think the next few years are going to be exciting to see if there are specific dietary patterns that really can become recommendations. So lastly, I want to talk to you about sleep. So we know sleep deprivation impairs attention. I think everyone in this room has probably had a sleepless night before and noticed the next day. Sleep is also critical to the overnight consolidation of memories. If we prevent people from getting adequate sleep and test their memory the next day, they do much worse than those individuals who are allowed to get sleep. Problems with, like medical problems with sleep, such as sleep apnea, which is when you lose oxygen during your sleeping, and it kind of chronically wakes you up, and it also means that your brain's not getting enough oxygen while you're sleeping, is associated with a lot of cardiovascular risk factors and also cognitive decline and dementia. So we know that poor sleep quality, so self-ratings of how rested people feel, how many times they're waking up during the middle of the night, is actually related to cortical atrophy, so the brain shrinkage, and the highlighted regions are the ones that are most impacted there. When our sleep is fragmented, so if you're waking up a lot, a common issue as we age is needing to go to the bathroom more during the nighttime. This can cause sleep fragmentation, which is also not good for your memory and thinking. And there's a lot of strategies that people can use, such as fluid restriction. After a certain point, it's very hard to adhere to, but that can help with managing some of that and prevent the cognitive decline associated with sleep fragmentation. On a positive note, we know that when we don't treat sleep apnea, so the standard treatment for sleep apnea is a CPAP machine. They're really hard to, most people don't like them. They're annoying to wear a mask. However, when people can adjust to it and start using it, we can see a benefit to it. So we know with untreated sleep apnea, cognitive decline is accelerated. However, even in patients with Alzheimer's disease, when you have a group treated with the CPAP machine versus a group not treated with sleep apnea, with the CPAP machine, in the group that has the CPAP, we see stability across time in their global screening of their cognition versus the people who are not treated who have a decline. So in summary, pathology is important, but it's not the only thing that matters. There's still a lot that we don't understand about the factors that predict who is, in the face of pathology, whose independent functioning is going to accelerate faster or not. But I think personally, that's my main objective, is to increase independence regardless of the level of pathology. So sleep matters, staying cognitively and socially engaged, trying to eat a healthy diet, I'm not sure what that is, and staying physically active would be my top recommendations. Thank you.